I'd like to call on our last speaker, Dr. Fidel Cayón from Ecuador, acute scapholunate dissociation, assembly, and effective option for its treatment.
Thank you. Hello, I'm Fidel Cayón and I come from Ecuador, a little South American country not much known for hand surgery in these days. Now I'm convinced that we are working to make Ecuador a hand surgery leader in the world. I represent Mano, and yesterday these new times for Ecuadorian hand surgery began with the acceptation of Ecuadorian Hand Society as a member of the EFSSH. I have to thank Colombia, Chile, Venezuela, Mexico, and España and Argentina that give me a hand in this. All the international representations of the hand societies give the welcome yesterday to us, so many thanks to you, and I'll be sure the Ecuadorian work will be important for world hand surgery. Okay, now we'll talk about an A assembly. This is a kind of surgical immobilization that we can use in an acute scapholunate dissociation that is the most common cause of carpal instability. We think that an A assembly is an easy way to recover the carpal kinematics and allow to heal the broken ligaments that are involved in this pathology. It's important to remember that in a ligament lesion, the healing capacity evolves quickly in a 3 weeks period, allowing us to restore the ligament continuity and having a good healing for restore the carpal kinematics. The scapholunate ligament has an U or C form in what the dorsal part is the most important for its strength. Then we have a partial lesion just only in this dorsal zone. We have difficult to diagnose because of the resistance that the rest of the ligament gives to the joint. The problem is when the rest of the ligament fails and the scapholunate joint shows as the dissociation, but in this moment it's too late to restore the kinematics, only with immobilization because the impossibility of the ligaments to heal. In the cases we found the lesion as quick as in the first 3 weeks, this is an acute period, we have to restore the anatomy and immobilize the scapholunate joint with K-wires. First, like an axis between the two bones. That is important because it allows to join a scaphoid with the lunate. And after that, we use 2 K-wires more using the capitate as a fixator in this case. This we call a assembly. This is a very good option that allows us a small movement of the radiocarpal joint that is good for the recovery of the patient. We evaluate the results obtained by images, the strength in the hand, the pain, and the range of movements in the cases operated by our team and evaluate the results of this treatment. This is an example of one case of scapholunate dissociation accompanying a scaphoid fracture in a 22 years old male patient. He had a break through an accident in a motorcycle. We used the A assembly restoring the carpal kinematics, and in this case, a screw for the scaphoid. In our 7 cases, we found a reduction of the joint in 100% of the cases immediately after surgery. 3 months after the injury, only 1 case had scapholunate dissociation. Also, clinically, it remained asymptomatic. The pain was 2/10 in the visual analog scale. The range of motion averaged the 80% of the contralateral side, and the strength reached 80% on the contralateral side. In conclusion, we think this is a valid option to solve this problem. We found the most important problem now is to diagnose the problem during this 3-week period. But now we are performing a wrist arthroscopy to try to make a very quick diagnosis. In the patients with distal radius fracture or with the scaphoid fractures or with wrist trauma with highly scapholunate dissociation suspected, we perform now an arthroscopy. We are sure that this will allow us to diagnose much more cases than in other way can be diagnosed too late. I don't have more to say that in Ecuador, all of you are welcome. We have a little country, but a very big heart. Thank you.
Thank you, Dr. Perez. Could we have any question from the audience? One last question. Scott, do you have a comment?
How acutely do you need to make this repair in order for it to be successful? And why do you think that pinning leads to healing of the scapula? What do you have? Let me go back. How quickly do you need to repair this? And do you ever do a repeat arthroscopy to assess your scapholunate healing?
We didn't do arthroscopy. And we have to check and diagnose this before the 3 weeks period. Is before 3 weeks.
2 weeks, okay.
Okay. We said that after 3 weeks, the healing capacity of the ligament is so much less than in that period of 3 weeks. And the problem is to diagnose that rupture of the ligament in this period of 3 weeks. Right. Then now we are trying to assess the fractures of the radius, the fractures of the scaphoid with arthroscopy to evaluate the ligament and to be sure that it's not broken, or if it is broken, make an assembly.
And am I correct, these were closed reductions? With closed reduction with percutaneous
Yes.
K-wires?
Yes, closed reduction with percutaneous.
Well, I'd like to thank you very much for that presentation, and thank you to the audience and to our speakers for your excellent presentations this afternoon. Let's enjoy lunch.